We're going to start with the first lecture on the language to describe a fracture by Dr. Batowi.
Thank you very much for the introduction, Marcella, and welcome all of you who have joined us today for this session as part of the post-operative metalwork course that has been put together by Marcella and the rest of her team. It's a real honor to be part of this, so thank you for including me. My assignment today was to cover the language used to describe a fracture, which will be new for those of you who are just starting reporting as junior radiologists, or those of you who have decided to become reporting radiographers. But for those of you who are very familiar with plain film reporting, this is going to be a bit of revision and an opportunity for you to relax a little, I hope. So in terms of describing a fracture, the first way to best start is to describe the orientation of the fracture. So these can be transverse if they're along the short axis of the bone.
Can we please remind people to mute yourself? Can we remind people to mute, please? Hiba, I think you can mute people. Sorry, Bhavna.
That's okay. Thanks, Marcella.
Okay.
So linear fractures are along the long axis of the bone, and oblique fractures will be at less than 90 degrees to the short axis of the bone. There are other fractures as well, such as spiral fractures, which are sometimes seen in toddlers' fractures, for example. Green stick fractures, which are also usually a childhood fracture, and comminuted fractures, which occur when the fracture is broken with more than 2 fracture fragments present. So as I alluded to earlier with the green stick fractures, these are often fractures that occur in children, and children have a lot of elasticity in their bones. So they may have fractures which are the result of bowing, where you don't actually see a fracture line, but the shape of the bone is distorted. You may get a buckle or a torus fracture, as you can see here, and that might just appear as a ripple or a little bump on the cortex of the bone. In this instance, we can see actually a break in the cortex on the radial side of the distal radius, but a torus fracture may just have a similar appearance to what you can see here on the ulnar side of the distal radius. And in addition to that, in children, you may get green sticks fractures where just one cortex is broken and the other one remains intact. That may appear just as a bit of distortion in the shape of one cortex. Finally, another type of incomplete fracture that we see, this time in adults, is a stress fracture or an insufficiency fracture, which is the result of excess load or stress on normal bone. And that appears as an area of periosteal reaction or cortical thickening in more chronic cases. These commonly occur in the metatarsals, but on occasion, the medial aspect of the proximal femur is another common location for this sort of injury. Then so after fracture orientation, location is another important thing to consider. So just as you would describe a bone lesion, it's important to describe the location along the long axis of the bone. You can either use the terms epiphysis, metaphysis, or diaphysis if it's a long bone, but sometimes proximal, mid, and distal third are appropriate as well. So for example, when describing a fracture of the clavicle. And it's important to mention whether there is intra-articular extension or not. And I will go on to talk a bit more about intra-articular extension shortly. For some fractures, the location is best described depending on the specific bone. So, for example, if we're talking about the metatarsals, it might be appropriate to describe a fracture at the base or the shaft or the neck of the metatarsal. Scaphoid fractures as well, for example, it's best described as involving the distal pole, proximal pole, or the scaphoid waist. And the same applies for the talus. And some fractures may involve just specific parts of a bone. So for example, a condyle, different aspects of the femoral neck, or a tuberosity in the proximal humerus, for example. So be as descriptive as possible with regards to the location of a fracture. Going back to children again, the Salter-Harris classification of fractures is important as well. So these fractures involve the growth plate, and it's important to describe whether they involve the epiphysis, the metaphysis, or go through the growth plate. Then the next aspect of describing a fracture is in terms of its displacement. So fractures may be angulated, the distal fragment may be rotated or translated. There may also be separation of the fracture or distraction where the two ends of the broken fragment are pulled apart, or conversely impacted, like here in this fracture of the base of the fifth metacarpal. So this fracture is impacted and there may be a bit of shortening of the bone. Sometimes the fracture fragments may override, as you can see here. So the other thing which is important to mention with regards to displacement is best described as the position of the distal fracture fragment relative to the proximal fracture fragment. So in the example here of this left femoral neck fracture, it would be best to describe it as proximal migration or proximal displacement of the distal fracture fragment, and some of these and some of this fracture is overriding as well. And as I said again, I can't say it enough, displacement is most accurately described as the deviation of the distal fracture fragment relative to the proximal fragment. So when we talk about displacement, as I mentioned, we can describe angulation. So that can be in a varus or valgus plane. It may also be dorsal or volar, particularly if we're talking about fractures at the wrist, or even medial or lateral if that's more appropriate. Rotation can be either internal or external, and translation can occur if the bone is moved medially or laterally with respect to the proximal fragment, and if the two fracture fragments don't connect at all, that's best described as off-ended. And as I mentioned before, you can get distraction as well of different fractures. So when we talk about intra-articular extension, I generally describe it if it's more than 2 millimeters. Anything less than 2 millimeters, I don't usually measure. So when you're describing intra-articular extension, make sure to detail which joints are involved. So here, for example, the fracture extends to the radiocarpal joint, but in some instances, it may also extend to involve the distal radioulnar joint, as it does here as well. Also, I described the separation of the intra-articular fragments, so that distance there. So describe the separation of the intra-articular fragments either in a antero-posterior or mediolateral plane, depending on the site of the fracture as to which is most appropriate. And the other thing to bear in mind with regards to intra-articular extension is the intra-articular step-off. So that's looking at where is the articular surface relative to where it should have been. So for example, here there's a depressed fracture of the lateral tibial plateau. And I would expect the articular surface to be here where this arrow starts. So I would measure this distance from where I would expect the articular surface to be to where it is now. And as I said, anything more than 2 millimeters, I would include in my report. Finally, it's important to describe whether the fracture has resulted in dislocation or subluxation of the joint involved. So if there is some contact between the articular surfaces, then it is subluxed. Otherwise, if there is no contact at all, then there is a fracture dislocation. I don't always use fracture classifications in my reporting style. There are some which I use, so the Schatzker classification to describe tibial plateau fractures I do use quite commonly. There is also, for example, here the Hawkins classification for talus fractures. But what I would really recommend people do is familiarize yourself with these fracture classifications so that you know which aspects are important to describe. So for example, here, if we were talking about the Hawkins classification, it's important to know that the fracture goes through the talar neck, and then describe what kind of involvement there is at the subtalar joint, if any. And the same for the Schatzker classification. Usually tibial plateau fractures are going to involve the lateral tibial plateau, but is that just a simple lateral tibial plateau fracture? Is it depressed? Does it involve the metaphysis as well? Those are other details that you can include in your report to best describe a fracture. Okay, so for the final couple of minutes, we're going to get a bit interactive. So I'd like you to go to menti.com and enter the code. I'm just going to swap my screen to see how many of you have joined. So I've got 5 people joined, 6 now, so maybe we're getting a bit closer. Excellent, I can see more of you are involved. Perfect. So what I'm going to do is I'm going to show you three different fractures, and you'll need to select the option which would best describe a fracture, bearing in mind the things that we've just covered. So I will show you the first image. So here we go. This is the first image. I, of course, am not going to describe the fracture, but you can have a look at it. I will come back to this. Okay, several of you have joined. Okay, so how would you best describe the fractures of the 3rd and 4th metacarpals? Go back to it so you can see it. So are those spiral fractures of the metacarpal shaft, oblique fractures with dorsal displacement and shortening, oblique fractures with volar displacement and shortening, spiral fractures with carpometacarpal joint dislocation, or non-displaced oblique fractures? I'm having some trouble here. Sorry. Marcella, can you still hear me?
We can hear you, Bhavna. It's fine. Take your time. Don't worry.
And the screen is frozen?
Yeah, the screen is frozen, and we have a person saying that the connection is lost to the quiz. So it's not showing anymore the question.
Okay, give me, I'm going to stop the sharing and load it again.
Don't worry, don't worry.
Sorry.
This is happening in real time. This is what we get when we go virtual.
Exactly. Google Chrome has failed me.
Oh, probably the connection in the hospital. Some people say it's working fine.
Some people have it, okay.
Yeah.
Okay.
Some people are saying that if they wouldn't complain for a second chance. It seems that they got it wrong.
Okay. Fine. Okay, I'm back on. I think I'm having some success now.
Yeah.
So let me just share my screen again.
Okay.
Sorry about that, everyone.
No, it's fine. These things happen.
Okay, fine. So this was the fracture that I showed you. And there we go. So one person was the star. So these are oblique fractures with volar displacement and shortening. So as we said earlier, you need to describe displacement of the distal fracture fragment relative to the proximal fragment. So hence the issue there. Okay, next one. I will show you the image. And now we will go back to the question. Now that you have your options, I'll show you the image again. We've got 22 responses, so that's pretty good. Many more people. Yeah. Everyone's voted. Brilliant. Absolutely. So the third option, undisplaced fracture of the distal pole, is correct as well. But the fourth option is more descriptive because it includes the involvement of the joint as well. So that's why this is a better description of the fracture. And some of you have also chosen the option with an intra-articular step. So there is a tiny intra-articular step here, but I think that that would be less than 2 millimeters. So therefore, I wouldn't consider that to be significant enough to need to include in the report. Obviously, I have not given you a measurement here. All right, and final image, and I'll move on to the next question. So how would you best describe this fracture? Okay, 10 of you, many more responses coming through. I know that about 30 of you are logged in, so we're at 26 responses, so that's good. Everyone's voted. Brilliant. So you've all seen, of course, you've seen the fracture, but you've also seen that the bone at that site of the fracture is abnormal as well. So if we go back to it, well done, everyone. So if we go back to it and we have a look at this, yes, indeed, there is a fracture. There are probably some overriding fracture fragments here as well. But if we look at the edge of the femoral neck here, you can see that the lesion there's a lucent lesion with a wide zone of transition. So this is probably an aggressive lesion. And if you needed more proof, here is the bone scan for that patient. So this was metastatic disease. All right, so some take-home points. I think it's important to be as descriptive as possible when it comes to describing a fracture. Think about fracture orientation, the location, involvement of the joint. As I said, I use 2 millimeters as my cutoff to describing whether the separation of the fragments or intra-articular step is significant. Always consider the presence of an underlying lesion, as we saw in the last case, particularly where there's been low impact trauma. And also, it's important to familiarize yourself with classification systems, even if you don't use them regularly in your reporting, just to know what to look for in particular fractures. Thank you very much for your attention.
Thank you so much, Dr. Batowi. It was a really good description. It's going to help you ensuring our normal practice and will help the orthopedic surgeons to look at our reports now, now that we're getting better at it. Is there are any questions to Dr. Batowi, or should we move on to the next one? If there's any question, please put it in the chat, or you can directly message me, or
I'm looking at the chat as well, so if there are any questions that people want to just send directly to me, that's okay as well.
Yeah. So it seems that everyone is doing right with the description of fractures. Thank you, Wafna. So now let's move on for the sake of time for the next lecture with Mr. Groom, who's an orthopedic surgeon from King's College, and he's going to talk about fracture non-union.
Thank you. Thank you very much, Marcella. Now, why can't I've got that and share. Can you see that, Marcella?
Yes, we can see it. Yes, perfect. We can see it.
Good. Good. First of all, may I say thank you to Bhavna, because I thought that was an extremely interesting way of describing X-ray reporting and describing fractures, and I loved the quiz. We might debate some of the answers, but I loved the quiz. I'm afraid I haven't been able to master the technology to introduce for myself. The second thing is, I'll stop waffling in a minute because this isn't waffle. I'm very sorry that David Elias, who is a hugely valued colleague, is not able to be with us, because I think that the two of us doing it together emphasizes the importance of partnership, and just me by myself might give the wrong impression that we are less reliant upon radiology and our colleagues than is the case. Anyway, we've been asked to talk a little bit about fracture non-union, and if we start with fracture union, which David has described as the restoration of mechanical properties of bone, including strength and stiffness, and I would agree with that. But union doesn't have to be uncomplicated. Malunion, as in this case, is the bone heals in the time in which we expect, but in an abnormal position. And it's really quite important to consider that the abnormal position can be in terms of angulation and rotation, and of course length. And plane imaging helps us in all those regards. Delayed union is somewhere in between, is perhaps difficult to define, but David has described it as a healing process significantly longer than is expected, perhaps more than 3 to 6 months. And of course, the expected time of fracture union depends on where the fracture is, the fracture pattern, and all those elements relating to the limb and the patient that we in orthopedics call the personality of the fracture. Sorry, Marcella.
Sorry, we lost you for a minute, but it's fine. It's fine.
Can you hear me now?
Keep going. Yes, keep going. Sorry.
Now, if we move on from delayed union, we moved on to non-union. Now, David didn't offer a definition, and it seems to me that if we're going to consider the problem of fracture non-union, a good place to start would be how to define it. And perhaps we'll come back to these other forms of non-union, but perhaps we could move swiftly on to definition. Now, there have been many attempts and not a huge amount of success. The AO manual, the AO organization, is one of the principal educators and innovators in fracture management. And 30 years ago, they described non-union as the arrest of the fracture repair process and the fractures remained ununited for 6 to 8 months. Well, the FDA have tried a definition when at least 9 to 12 months has elapsed since injury and the fracture shows no visible signs of healing for 3 months. That's not necessarily as helpful as it might seem. Mike Saleh was a guru of fracture non-union management, and that was his definition, published at about the same time, but that is, I put it to you, meaningless. I think the most useful definition, or it's certainly the one we use, comes from a classic paper on tibial fractures by Nickel. This is an ancient paper, but it's a classic paper, and he defines it as a condition in which, in the opinion of the surgeon, the fragments would not have united with further conservative treatment. Now, you might say to yourself, that's all a bit old-fashioned, but if you look up now a definition of fracture non-union, you will see the exact FDA definition produced in May this year. And if you look through the 960 pages of this very large book devoted to the management of non-union in 2010, it doesn't offer a definition at all. So just to reassure you, I'd like to say that we have updated the definition of fracture non-union. This is the one we started. This is where we started, and we've updated it because who wants the opinion of the surgeon? And so now it is the opinion of the MDT. So if we move on from definition of non-union, I hope that was valuable in thinking about fracture non-union, because if it's difficult to define, then it may be difficult to describe and equally difficult to manage. I think David's division of non-union into viable, in which the bone ends remain alive, and non-viable, in which they're probably not alive, is useful. And where the bone is alive, the causes of non-union may be inadequate stabilization of fracture fragments, and the pseudoarthrosis is what eventuates. And in this particular case, we have going, and gone. And that is a very, sadly, all too common example of inadequate stability in fracture fixation, which has contributed to non-union. And then, of course, we come back to what we would call the personality of the fracture, by which we mean the fracture in the bone, the limb, the patient, and if we're thinking about treatment, the capacity of the healthcare team. And we're concerned about vascularization. The picture shows a compromised left leg and the effect in the foot very clearly. And of course, we worry about the things we can influence: smoking, alcohol, and anti-inflammatory medication. Now, infection is a powerful cause of fracture non-union, and it's why we obsess about it. And David has found this figure of 38% of cases in which infection contributes to non-union. And this young woman had a closed fracture, failed internal fixation, and an MRSA sinus. I don't know if you can see my cursor, but in terms of this very straightforward plain film, you can see the soft tissue indentation of where the sinus is. So this has been extremely well known to you all, but it's useful to have an image of the soft tissues as well as of the bone. And if we move on to the clinical definition of fracture healing, which obviously is the reverse of non-union, the clinical the clinical definition or the clinical situation is often the most reliable. When a patient comes to clinic and says, I can walk on my leg, it no longer hurts, it feels strong, that's usually an extremely reliable feeling. The problem, of course, is when that is created, when that feeling of security is created by a rigid internal fixation, which then may fail if the bone doesn't heal. And then we come on to what David has done with the clinical definition of or the radiological definitions of fracture healing, bridging bone and callus with trabeculae across the fracture site, the bridging of 3 or 4 cortices or cortex on 3 or 4 sides, and the loss of the fracture line. And he's introduced these 2 scores, the radiographic union score in tibial fractures, which he calls RUST. And this score comprises whether or not a combination of fracture line and callus. If the fracture line is visible in anterior, posterior, medial, and lateral cortex, and there is no visible callus, then that scores a maximum of 4, and the fracture is clearly not united. If you can see the fracture line, but there is callus in all those areas, that will add up to a score of 8. And then there's that awful is it, isn't it united moment where the clinical input might help. If the fracture line is no longer visible and the callus is bridging, then the score will be 12 and the fracture will be united. That I haven't come across that before, this scoring system before, but it looks as though it has potential. And David also introduced a radiographic union score for hip fractures. I have to say I've never seen either of these quoted in radiology reports, but they are published and they may well have their value. This also refers to bridging and consolidation and to the visibility or otherwise of the fracture line. And it's slightly more complicated with a total score of between 10 and however much that is, 24. So there exists the possibility of scores for fracture healing and therefore for fracture healing reporting. And I think what he was talking about, let's go back to where we were, is that we're talking about callus and the fracture line. And if the fracture line doesn't reach the edge of the callus, then that suggests that it's united. Now, if we move on, what do orthopedic surgeons want from imaging, from plain imaging, and therefore from reporting? Well, if we start at the beginning, we generally want images of the whole bone, and we often want them unobstructed. And I'm not sure it's a reasonable ask for an orthopedic surgeon to want an unobstructed view of a tibia when we've put a rather expensive Meccano all around it, and we're obscuring more or less everything. There are 2 areas of interest. You can see the area of interest up at the proximal end of the tibia, and the other area of interest to us is almost entirely obscured by the tailor-spatial frame. But our radiographers are expert and well-versed, and they understand that if they just give us an oblique view, then we'll see what we want to see unobscured. So the whole bone, 2 views, unobscured. I think alignment with evidence of stability in fractures is something that we'd like to see. Now, this is a nail in a humerus, and this is almost, it's well aligned, but it's almost a definition of instability, because a straight nail down a humerus will confer zero rotational stability. And after a time, and that is a very potent contributor to non-union in the humerus. There's another little radiographic sign that we would look at for instability, and that's this lucency here. Marcella, can you see my cursor? Can you see my arrow on the screen?
Yes, we can see it. We can
Good.
follow, yeah.
Thank you. So this little lucency suggests it's on one side of the screen and not the other, and we would call that the windscreen wiper effect, because it suggests that there is movement of the distal fragment around the nail, which is causing an erosion within the bone. So alignment and evidence of stability. Now, this is another situation in which we're interested in alignment and stability. What I was hoping at this stage, but I have absolutely no idea how to manage it. And it may not be fair because it's quite a challenge for, it's a fairly challenging case. But if anybody felt like, if anybody wished to comment on the appearance of this X-ray, which is just different views, all of the same thing, then I'd be, you know, I'd be very happy to hear any comments. I'm not quite sure how best to do that. If anyone wants to put up, was that ping? Somebody putting up her hand?
Let me see. If you want to comment on the chat, people can comment on the chat, or if you want to raise your hand, we can unmute you.
Yes, yes. I think that what we were, I think that this is an orthopedic heart sink case, and what has happened to this poor fellow who's had a segmental fracture of his femur? He's had a fracture down here and a fracture up here. And over a period of 2 years, he's had 4 operations, one every 6 months. And at some stages, each one has failed. And so I suppose that's a bit like serial marriage and divorce. It's a triumph of hope over experience. And the point about this is, first of all, in terms of the radiographic appearance, that what we would be looking for is essentially an ununited fracture, a broken nail, and varus deformity. So while we have alignment in one sense, the lack of the normal hip shaft angle of the femur and going into varus means that we've lost alignment, and perhaps we have early degenerative change in the hip. But those would be the sort of the key features: an ununited fracture, a broken nail, and loss of alignment. And in order to get this to heal, all we have to do is to restore the alignment. And obviously a certain amount of planning goes into that, remove the metalwork, change it, and restore the alignment so that it's back into valgus rather than in varus. So alignment, and this device gives much better stability, and after 4 operations over 2 years, this will heal in 12 weeks. Now, So that's what orthopaedic surgeons sort of want from plain imaging, and it's the information that they want. Now, what David and I had discussed, perhaps without discussing the means by which we would achieve the discussion, was that we would then introduce some cases for discussion. And this is the first one. This is a young man of 25 who sustained this injury just running down a hill. He has a background of Crohn's disease, diagnosed 4 years earlier, and he's on azathioprine and biologics to control his disease. Now, I suppose a year after, not quite a year, 8 months after the event, he was still in trouble, and he was sent to, he came up to King's from his treating hospital, and we met him in February this year, and those were his x-rays. I'm not sure that, would anyone care to talk about them? Was this a bit, I'd be very happy to hear if anyone wants to
if anyone wants to comment, please just unmute or put it in the chat. It would be nice. It's not wrong answers. We all are learning. There's some comments in the chat. I don't know if you can see that, Grim. Retain drill bit.
I ought to be able to, shouldn't I? Where's my?
In the chat option.
Oh, my chat seems to have disappeared. Oh, there we are.
Okay.
My chat is not revealing itself.
Okay, so I can tell you. So someone has said there is a retained drill bit. Someone else has...
Well spotted.
Okay, someone else has said from X-ray perspective, it would be nice to see the full nail.
Yep, absolutely.
Someone else said there's a blade plate.
Yes, I think, well, I would say, first of all, well spotted about the broken drill bit. I would say absolutely correct. We do need to see the whole nail. It's not a blade plate. It's an intramedullary nail, and I think that this takes us back to the days of film radiography, which still exists in some parts of the world. It was always, this may have no relevance in the UK at this stage, but it might elsewhere. The problem with giving a name to an implant is that if it was inaccurate, we were told that the record of the examination was the report, not the film, and in due course the film was destroyed. So that was a sort of a pitfall about describing the implant. But I suspect, and perhaps misinterpreting it, I think that probably doesn't apply anymore. Marcella or Ravna would know that. Are the images stored indefinitely now, and is there a change in the legal definition of the record of the image?
Yes, I agree. Yeah, I think they are kept now. Everything is online,
they're kept permanently. So that really doesn't matter. This is an intramedullary nail, and I think when we first met it, the other things of interest are that there does seem to be new bone there. Does seem to be new bone, but it's not at all clear whether or not it is healing callus or what we would call irritation callus, which suggests new bone responding to low-grade infection. Anyway, when we met him then, we thought that he was well on the way to uniting, but his symptoms didn't improve. He continued to have pain, chiefly in the knee. And so we thought we would have a closer look at that. Now, if anyone wants to make a quick comment about those 3 randomly selected slices from the coronal reconstructions of the CT, perhaps we could wait a moment.
So feel free to post your answers in the chat, and I will read them out loud. Someone also said in the same case, in the X-ray, there was varus deformity. Okay, someone
yes,
here.
There was a varus deformity. That's absolutely correct. Well spotted. Thank you. Yeah.
So someone said there is lucency at metal bone interface.
Where here? Is that what we're talking about?
I think in the CT.
Oh, on the CT. Okay.
Yeah. Someone else says there are no signs of union. Doesn't appear to be any bridging of the fracture line by callus.
Yep. Anything else? This is I can't actually get at it because the gallery view is obscuring. Let's see if I can. There we are. Now, if the thing that I was hoping someone might spot was that, and perhaps that, because I would agree that the fracture is ununited on CT and that goes all the way through. The fracture line is visible. And when we're concerned about low-level infection, we would regard that as possibly representing a sequestrum, and we link a sequestrum with the possibility of infection. And that would guide our management plan, so that if he was going to need further treatment, if he didn't unite, we would be careful to follow a protocol for potential infection of an organism of low pathogenicity, which would involve withholding antibiotics, removing the metalwork, multiple specimens harvested separately, and sent to microbiology before antibiotics were given. So he was a current one, and now there was another case for discussion. This is a very courageous 77-year-old who's had more operations than you would care to imagine, only his most recent ones with us. The thing we're concerned about is that he had an arthrodesis of his left ankle 4 years ago in 2016, and that was revised to a hindfoot fusion with an intramedullary nail 2 years later, exactly 2 years later. And then he developed a stress fracture at the tip of the nail in December 2018. Now, what we did for him, and here comes the question. What we did for him was to take the nail out, break it, complete his stress fracture, complete his insufficiency fracture down here, straighten him up, and then lengthen him from a proximal osteotomy. And the reasons for that are perhaps for another time. Now, we come to the question, the vexed question of when can we remove his frame and have the fractures united. In this case, there are 2 separate issues. There's the issue of the distal fracture, and there's the issue of whether or not the proximal distracted callus has consolidated. Now, I don't know if we're getting quite ahead of ourselves talking about the consolidation of distracted callus, but the fundamental problem remains, has the distal fracture united, and is there enough support proximally to allow us to take the frame off? Now, if anyone cares to offer an opinion, then we'd be very happy and we could discuss it. But I do understand that this might not be exactly what you're used to looking at and perhaps to reporting.
Yeah, I'm waiting for some comments. Your question is regarding both fracture, the osteotomy and the distal tibial fracture, right, Room? Yeah.
That's exactly right, because what we want to do is, this is the 8th of June, and he's had his spatial frames, had a circular frame on for at least 9 months, and we're wondering whether he's consolidated sufficiently to remove the frame.
Yes, some people is saying that, okay, Bafna, you can unmute. Someone is saying there is a fracture line traversing through the distal tibia.
Yes.
And the distal fracture, at least in the lateral quarter, there is clear separation still. If anyone wants to comment, feel free to unmute and just offer a comment.
Yeah, hi.
Hi, Bhavna.
I can give you my opinion if nobody else is keen to unmute. So, firstly, looking at the site of the osteotomy, there's not much bridging callus at that site. There's a bit posteriorly where there's thick bridging callus, but I would feel that overall that's not united. And with regards to the distal tibia at the site of the fracture, there's some anterior translation at the site of the fracture, but there is bridging callus. However, I still see the fracture line quite clearly demonstrated. So this, I personally find these things quite difficult. So I would really value how you would prefer us to be reporting the distal fracture fragment in this instance.
Well, I agree. Thank you very much for that. I agree with you. I think it's extremely difficult to interpret. And I think if we, the thing that is most worrying is the large hole in the distracted callus proximally, and you think there's nothing there at all. And this is where it's a bit of a balance for us, and we're uncertain about it. We took the decision, aided by plain films, that he probably was united sufficient to remove the frame. Now, our protocol when we do that is to remove the frame in clinic and to keep them touch weight bearing for a couple of weeks, and then slowly to increase their weight bearing after that. And this is a very reliable person. But what happened was that he was, well, there are a couple of things here. First of all, if we compare the proximal, the image of the consolidated proximal distracted callus on plain film compared with the CT, this is the plain film that is so reassuring. It really looks as though it is united, and in the event it was, sufficient to bear his weight. And then when we look at his consolidated fracture distally, he was completely pain-free for about 6 weeks. And then he developed pain and he developed deformity. And so over on this side, on the right of the screen, we've had to put the frame back on the distal segment. And I think the really sharp-eyed amongst you will have spotted that after a year of grueling treatment with an external frame on his leg, we've converted his varus deformity to a valgus one. Poor fellow. I think that this case for us illustrates the huge difficulty of assessing not only when distracted callus is consolidated, but when fractures are united. And that's why I've included it. What we're doing over here is, because we know he has a lot of callus, he had some from the original stress fracture and he had more from after our operation, is that we're now, he was keen to achieve more length, and we think that he'll unite if we simply distract his callus. Now, if you think what information do orthopedic surgeons want, we also want to know about abnormalities within the bone. Now, we're near the end. We're also near 2 o'clock. And so there are just a couple of cases for us to consider the issue of sinister signs of infection or bone pathology, perhaps. Now, this patient is 41 years old and came to us after a football injury. He's of Somali heritage. And if anyone has any idea about what this might represent, other than a proximal tibial fracture playing football, then perhaps you could just quickly chat. Marcella, are we overrunning? Do we have...
I think we are too, but if people is happy to stay, we can continue with the discussion. I just want to say, if you have to leave, please don't forget to fill in the feedback, and you will be able to get the CPDs, but also the recording of the lecture. But if you want to stay to finish the discussion, that would be great. And if you have any answers also, any questions, please stay and we can discuss that.
Thank you.
The feedback has been sent to the chat, so everyone can access that now.
Okay, thank you, Hiba. So we have some comments on that playing field. Some people is saying that this suggests rickets, others like probably Paget's. Yep.
Thank you. Very good. I think that this patient had first of all turned up 10 years earlier, and he had a painful tibia, and he was thought to have osteomyelitis, which wasn't confirmed, and then he disappeared. And when he reappeared, that appearance was, we had several reports and discussions with our colleagues who thought that that also represented osteomyelitis. But in fact, it is, as some sharp-eyed participants have said, it does represent Paget's disease, which is unusual at that age. But that's what it is. Now, this is another case, and this is our last case, really. It's a professional football apprentice professional footballer with a grade 1 open tibial fracture that was treated by debridement and an intramedullary nail. There were evidence of infection, and he had an exchange nail very early. This is the only case that is not a King's case. Union was said to be delayed. 8 weeks is very early for an exchange nail in orthopedic practice. At 3 months, his X-ray looked as it does on the left of the screen, and at 5 months, as on the right. I'm very happy to let anybody who wishes to comment on this appearance, but I think what we're finding...
I'm happy to chat.
Okay.
So looking at the images from 3 months to 5 months, there's been progressive lucency around the screws and the intramedullary nail. Also, there looks like there's some areas of bone resorption as well. So I'd be concerned about infection here, primarily.
I think that's it. I think that was exactly what happened to this poor fellow, and infection and instability, with more of this windscreen wiper effect, with the distal fragment moving backwards and forwards, loose screws which are backing out, and this poor young man. This is an old case, and we would hope it wouldn't happen now. But the end result of the treatment for this grade 1 open fracture in a young footballer was amputation. But it's the appearance of the x-rays for which we included him. I think what we have not done is discuss at all the issue of non-union when there's a substantial bony defect. And I think the imaging of repairing bone defects is probably a matter for another time. We're 4 minutes past 2, and I'm very grateful for your attention, and I'm very grateful to Marcella and Bhavna for asking me to contribute. Thank you.
Thank you so much. It has been a really useful lecture.